Morning to all of you. Uh, we at Positive Physiotherapy today we are presenting a webinar on a very interesting and a different topic, which says that the perspective of physiotherapy in organ transplantation, specifically in the abdominal organs. To present this webinar with us, we have respected Dr. Harda Shah ma'am. She has done her MPT in cardiorespiratory sciences and she is also a PhD scholar. She is a senior lecturer in physiotherapy, also a PG guide in transplantation rehabilitation, Gujarat University of Transplantation Science, and she is working currently with Institute of Kidney Disease and Research Center and Institute of Transplantation Sciences. She's in the field of physiotherapy since last 20 years, and she has 11 years of experience in transplantation rehabilitation. Ma'am, we are honored and we feel very good to have you with us to present this webinar because there are a lot of topics being taken around the globe on webinars talking about physiotherapy and other medical professions. But I think this is the first of its kind which we are presenting from Paranstop Physiotherapy, where we are going to talk something regarding the perspective of rehabilitation and physiotherapy in organ transplantation. I hope all the audiences will enjoy this and they will gain a lot of knowledge from ma'am. Ma'am, thank you very much to accept our request of doing this webinar, and we are obliged to have you.
Good morning, one and all, and thank you very much, Dr. Dharmang, and specifically Parul University for showing keen interest in the relatively new topic, that is transplantation rehabilitation. Right now, I request one and all to please mute their audio. So the whatever communication we will be doing it later on in the end of the presentation. Right now, I am sharing my screen. Is it visible to one and all?
Yes, sir.
Yes. So, Dr. Dharmang came with a proposal that, ma'am, can you take the presentation on transplantation rehabilitation? So I just convey that yes, it is a relatively new area, and I will be very much enlightened to spot a light on the area of transplantation rehabilitation. So I am presenting the scope and practice of transplantation rehabilitation, that is the physiotherapist perspective in abdominal organ transplantation. So on one or another day, one may be exposed in the newspaper or reading in the newspaper that someone brain dead persons had donated his or her organs to a needy persons, like a liver transplant has been done in the Madras and the kidney transplant has been performed in the Ahmedabad, or her or his heart has been shifted to the New Delhi, and where the heart transplant has been performed. This is just today's newspaper headline that was showing that one female who was a brain dead, and she donated her 5 organs like heart, lung, 2 kidneys and liver, and then because of that the 5 needy persons got a new life. So that is the importance of how the organ donation is been evolving day by day in the India, as well as on the other side the requirement for this organs are also increasing, and that is why today's topic is like because it is increasing day by day, we have to build our knowledge and gain certain aspects of how we can help to the persons who require a transplant, and if once a transplant has been happened, what can be done on the physiotherapist part so that we can help them to improve their quality of life and retain or regain their previous the physical abilities and various qualities of life ahead. So in my presentation, I will be covering few parts like inter-organ crosstalk, how the various organs are interrelated to maintain a normal internal environment at a base. Secondly, I will be covering the aspects of global burden of chronic diseases and how they are affecting our lives. Then we will be covering the aspects of physiological derangement in various organ dysfunctions. Then we will be covering the part of what is organ transplantation, its definition, how it is being performed, which are the classifications of organ transplantation, and the development of the phases of transplantation rehabilitation and how it is being performed. And there are various challenges, and I hope you all people will enjoy this journey of the learning of transplantation rehabilitation. So in our body there are various vital organs are there. As such, I will be talking about mainly of the abdominal organs, but let us revise various organs like brain, heart, lungs, intestine, liver, kidneys, musculoskeletal system, bone, all are interrelated. So there is a metabolic crosstalk that is called the interconnected crosstalk between the various organs. Why that is there in our body? Because in the normal physiological state or in a disease state, they are in a continuous connection. Like recently, because of in this COVID area, we have came across that because of only involvement of lung, there was also involvement of various organs, followed by because of the dysregulation or the loss of connectivity in the this interorgan crosstalk. So we will be looking after that how beautifully these organs are interconnected and they are linked and they are maintaining the normal homeostasis of our body. In the day-to-day activity, we are covering with various aspects of mental, physical, lots and lots of stress. The lifestyle is being also very much altered. We have become more of sedentary. There are lots of habits because of the social media and the peer groups. There are various habits of alcoholism or smoking, junk food, eating of habit of junk food, excessive salt and sugar intake, all lead to development of hypertension, high blood glucose, high cholesterol. What all these factors lead to? There is that all these factors create imbalance in our normal homeostasis, and so our vital organs like kidneys, livers, heart and lung, they are under stress. The capacity to sustain such stress, every organs have a certain ability to sustain this stress, but when the stress level increases at a certain amount, these organs start failing. That is called sequential organ failure. India is a fast developing country, but in the global systemic analysis of the global burden of disease study that was published in the Lancet suggested that out of that 8 to 17% of the Indian population are suffering from various type of chronic kidney diseases. Out of that, 4 to 9% of these Indian populations are suffering from any form of liver diseases. There are various grades of kidney diseases. Certainly, the chronic kidney disease is the dysfunction of the kidney when the glomerular filtration rate, that is a basic function of the kidney, is to form a urine to remove certain toxin, that is unwanted toxin from the body. That also maintains the electrolyte and balance, and it is important to form a precursor of hemoglobin, and it also helps to maintain the blood pressure. But when this kidney start failing, there are various stages of kidney failure, and it has been classified from stage 1 to stage 5, that with the deteriorating function of the kidney when the output of the kidney or glomerular filtration rate is reduced, and in the last stage it is called the end stage kidney disease when the glomerular filtration rate is less than 50 ml. of a body surface area. There are various forms of kidney disease are also there. Initially, a few of your family members or the other persons may have been diagnosed with a fatty liver disease. That is the first stage in the development of liver failure. Okay, and it is a progressive disease that will ultimately end up into the fibrotic lung disease, that is called streptohepatitis, and ultimately it may end up into the end stage liver disease. Out of all these chronic inflammatory disorders of the kidneys and liver, 1/3 of this population end into the advanced stage of disease, where it is an irreversible disease when one cannot, the medications cannot help out them to manage or sustain their life. For the kidney patients, the only option available is a dialysis. Either they have to opt for a dialysis or either they have to opt for a kidney transplantation. But unfortunately, for the subjects who have been diagnosed with the end stage liver disease, they have to only wait for any such liable functioning liver that can be donated either from one of the family member or a deceased donor, that is brain dead donor, or they have to wait only till they die. So in the scenario, that is that every 10 minutes the someone is added to the national transplant waiting list. India has that specific guideline, that is national NOTO, that is National Organ Transplant Registry of India, that whatever persons they are requiring any organ, they have to register themselves first to this government body, and then there are more than 500 transplant center that they have to register themselves to get a viable organs. During that waiting period, sometimes it may possible that the patient during that waiting period may die because of their various comorbidities. So in the study, every day around 21 people die each day waiting organ donation before transplantation. So let us revise that what is organ dysfunction, that I have just put a light up on that. But because of that organ dysfunction, there are multiple physiological derangement happens. Which are this physiological system? That is not a single system that remains unaffected because of this organ dysfunction. So there is a cascade of various inflammations. There is endothelial damage that affects the circulatory system. The pulmonary functions are also reduced. As for example, in the subjects on the dialysis, they have a fluid overload because the excessive amount of fluid, there is a difficulty in removing the excessive amount of fluid from the body, and because of the electrolyte imbalance, there is a pulmonary congestion that is called pulmonary edema. Itself, it is decreasing the pulmonary compliance, and there are various forms of obstructive and restrictive lung pathologies are seen. When I give an example of liver failure or in the end stage liver disease, the patient having huge ascites. The ascites is a collection of fluid inside the abdominal cavity that will itself lead to mechanical disadvantage to the diaphragm and will lead to restrictive pulmonary conditions. So it also reduces the cardiorespiratory fitness. How? Because of the pulmonary edema, there is a negative feed-forward mechanism that will lead to congestive cardiac failure because of various atherosclerosis and calcification in the vascular wall that will lead to cardiac overload. So these subjects may be having or may be suffering from various forms of decreased aerobic capacity. There is a cardiac hypertrophy, dysfunction like related to cardiomyopathy also present. Is when I give an example of liver failure, these patients are in the state of metabolic hypermetabolism. I'm sorry. They are in the state of hypermetabolism. So their resting metabolic energy consumption are high. They are in the negative calorie balance because they are also having a restrictive diet. Protein and fluid restriction is also there. That will lead to decrease in the energy and decrease in the muscle mass. there is increase in the metabolic state. So overall the muscle mass is reduced. They have decreased diet, they have decreased appetite. That is a vicious cycles of fatigue, illness, and functional disability. Other part is in the skeletal. Let us see the skeletal system. What happens in the skeletal system? They have, because of the vitamin D abnormal synthesis and hyperparathyroidism and calcium deficiency, they have various form of osteoporosis, osteomalacia, and various mineral bone diseases. Hello, am I audible? I request to mute the mic. So because of this physiological derangement, what happens that the subjects are suffering from anemia, the hemoglobin level is quite low before transplant. When the subjects are being diagnosed with the chronic kidney disease, a patient of end-stage liver disease. So they are having anemia, they are having sarcopenia, there is a decrease in the muscle mass, they have decreased energy reserve, there is a mitochondrial damage that will lead to muscle dysfunction. Because of the circulatory and the oxygen carrying capacity is also reduced, that is a decreased blood flow and ultimately lead to decrease in the aerobic capacity, decrease in the muscle strength. So and ultimately all this oxygen delivery system is at failure. So what happens in this state? There is a decrease in the physical fitness, decrease in the nutritional state, ultimately leads to decrease in the cardiopulmonary endurance, functional deterioration, and sarcopenia. I'm sorry. These patients, either they have to wait till death and they are suffering from various stages of frailty. That is a next step of sarcopenia. Okay, and so before this stage, the transplantation is an option that will reverse the negative spiral of deconditioning and hasten the process of physiological de-arrangement. And here is the role of physiotherapy to reverse this negative spiral by improving the cardiopulmonary endurance, improving the muscular flexibility, improving the strength, agility, and balance. And ultimately, finally, we can help them to regain their quality of life. So let us see what is transplant. Anybody know that what is transplant? So the synonymous of transplant is to graft, to transfer, or to implant anything. So in the ancient Indian mythology, the Lord Ganesha was the first individual who got a transplant done by our Lord Shiva. He is considered the transplant surgeon. Okay, but the foreign countries do not accept our this clause. And then in the history, if we see, the first transplant was performed in USA back in the 1954, and that was performed in two identical twins. That one child was been diagnosed with the end-stage kidney disease when he required hemodialysis, and they successfully transplanted one kidney from other identical twins. And from that, the transplantation sciences is ever evolving, and with the advancement and with of the recent immunosuppressant medications, ultimately the outcome after transplant is improving day by day. So coming to the transplant again, it is a move or transfer someone or something to another place or a situation. So as for example, that is either maybe a living tissue like skin or mucosa or a whole organ itself, and it has been implanted into the another part of the body or another body. So organ transplantation is really a gift of life. It saves lives and restores the quality of life for those who have been sick for a long time with the end-stage organ disease that I have covered, that they are suffering from various comorbidities, right? So transplantation has a potential to to either hasten or to revitalize all the physiological systems and to put a life into all the physiological system, so to sustain all functions. This is another definition of organ transplantation. It is in the medical terminology, it is a surgical procedure in which a failing organ is been replaced by a functioning one from the donor with a compatible tissue type. Means who can donate an organ? It is a complete entitled science itself. So there is a science that who need an organ, who can donate an organ, because if I wish to donate to somebody, it is not like that. There are specific guidelines, there are specific the rules and regulation that is covering the aspects of transplantation of a human organ. The organs that have been successfully transplanted, that include heart, kidney, liver, lungs, pancreas, intestine, and thymus. But out of that all, the worldwide, the kidneys are the most commonly transplanted organs, that follows by liver and then heart. It is one of the most challenging and complex area of modern medicine for the treatment of end-stage organ disease. And the success of any transplant depend upon the procurement. What is procurement? To getting an organ from a cadaver, that is a diseased donor, that is a brain dead, when when the brain is not functioning, but the circulation is already preserved, that is called the brain dead subjects, from which after a consent from a close relative is been taken, and from the legal guidelines and sign and consent, the organ is being procured from that donor, and then it is preserved in a special solution, that is been in a cold solution, and then it is being brought to at this the place where other surgical team is ready to implant in a needy person. So it also requires surgical expertise to procure the organ, to place the organ in the needy person, and after the surgery has been completed, the appropriate proper doses of lifelong immunosuppressant medications is very important. The process of taking organ from someone and putting inside is not a transplant process itself. After a surgical completion, the subjects has to be on an immunosuppressant medication for his lifelong period, because every organ has a representation and everybody has a native antibody and antigen reactability in their body. When the organ is implanted into someone, their own body do not accept that part or a organ, and it rejects it as a foreign material. To prevent this rejection, the various medications are used, and these medications are called transplantation medications. They are immunosuppressants because it reduces specific part of the immunity, and so such population are very much immunocompromised, and they require a regular follow-up. Coming to the various classification of transplant. So there are the classifications are based on three parts: from where the organ is being implanted. Second way of classification is based on the donor, and the third way of classification is where it is been implanted in the surface area of the body. So coming to the first part of classification is either autograft, isograft, or allograft or xenograft. So what is autograft? When some part of the tissue or a body is been taken and then implanted into the same subject, that is called autograft. As for example, if the skin is taken from the trunk and then it is been applied to the arm, it is called autograft. What is isograft? The isograft is when the transfer is happening between the genetically identical individuals, like monozygotic twins, or within the inbred strain, that is called isograft. Earlier I told that between the identical twins, when the one body part or organ is been implanted into the another subject who is genetically identical, that is called isograft. The another classification is the part of the classification is allograft. What is allograft? It is when the transfer happens between the different member of the same species. As for example, when my mother or my father or my siblings donate any organ to me, that is called allograft. So whatever happening right now, the scenario happening in the India, either kidney transplant, liver transplant, heart transplant, that is a type of allograft. Okay. Then what is xenograft? When the transfer happening between the members of different species, like from pig to the human, like we are transferring the various cardiac valves, that is called xenograft. That was the one classification of the transplantation. Coming to the another way of classification is from where the organ is being procured. That is living donor transplant or deceased donor transplant. What is living donor? Means viable living person is donating the organ, that is called living donor transplant. Either it may be related, means first relation, mother, father, brother, sister, that is related transplant, or unrelated, when the blood grouping is being done and then it is being donated to the another person, like cadaveric, like my uncle or auntie is transferring any organ, that is called unrelated living donor transplant. Coming to the deceased donor classification of transplant, that is either a brain dead person or a cadaveric when person is donating, that is called deceased donor organ transplantation. I already explained that what is brain dead. When there is a cough reflex is absent and 3 trials of spontaneous breathing is failed, the subjects are declared as a brain dead. What is cadaveric donor? That is when the circulatory death is also already there and there is a brain death, both are there, that is called cadaveric deceased donor transplantation. Coming to the third classification, that is when the organ is being secured or placed in the anatomical space where it is been already taken, that is called orthotopic transplantation. Let me explain in detail. That is like, as for example, in the liver, when somebody donate the, because the liver has a 2 segments, right segment and left segments, and when either related family person is donating a liver to another subjects who need a liver, after surgery, the liver has been implanted into the same anatomical position where the liver is placed, that is called orthotopic transplantation. But in case of kidney transplantation, the kidney is being transplanted in the different anatomical position than what is been we naturally having. Like that is called heterotropic transplantation, because most of the time the deceased kidneys are kept as it is, but the new functioning kidneys are usually implanted into the either right or left iliac fossa. That is called heterotopic transplant. So coming to the transplantation surgery in the brief. So to identify when the transplant is required. So there are various stages of transplantation. First is there is a development in the need of transplantation. If the person is being diagnosed with the end stage organ disease, he himself cannot define them, there is a need of transplantation, because I was already told that there are special guidelines, there are special medical evaluation that will assess the subjects for their requirement of an organ for a transplantation. That is the next step is pre-surgery evaluation, that is pre-anesthesia evaluation. There are various laboratory and radiological workup is being done before transplantation for fitness of their subjects to sustain or the stress of surgery for transplantation, because transplantation surgery is itself is a very complex and life-threatening surgery. Then the step is there is a availability of an organ, and then the surgery of organ procurement is being done. Before that, on the way, that there is a tissue typing is been done. Like any subject who require a transplant, they have to go for the phases of laboratory investigation, that is blood typing, like ABO compatibility should be there, and second is human lymphocyte antigen typing, that is called tissue typing. That is a DNA. Everybody has a special DNA coding, and that is been antigen coding, that any organ when implanted into the subject, it is possibly that our body may accept it or reject it. So whatever organ is being implanted into the recipient, there should be a maximum, we use a terminology that is maximum house match, that is the tissue compatibility should be maximum to avoid any rejection of the organ. Coming to the operation of a transplantation. So in the operation, after the organ procurement has been done, the organ is been put into the special solution. During that, there is no blood supply to the organ, that is called a cold ischemia time. Then the implantation process is happening during the in the OT, when the circulation is restarted with the anastomosis of arteries and veins, and that is called warm ischemia and reperfusion phase. Longer the cold ischemia time and warm ischemia time, the outcome is deteriorating depending upon their duration. So ideally, the goal should be shorter cold ischemia time, shorter warm ischemia time, so that the perfusion of the viable organ is started immediately. In the in this image on the left hand side corner, that is showing the incision in the kidney transplant. I already told that the kidney is being implanted other than the anatomical areas of the kidneys, and usually it has been implanted either in the right or a left iliac fossa, and approximately incision in the kidney transplantation is around 5 to 6 centimeter, and this is the Morrison modified Gibson incision, or it is also called the hockey stick incision. This is the hockey stick incision that is in the right iliac fossa. The subject is showing his incision, and this image is showing the incision in the liver transplantation, that is reverse Mercedes-Benz incision, and it is a quite larger incision and covering almost upper part of the abdomen. So whole of the thorax and the diaphragm is being pulled up, and the duration of the liver transplant surgery is quite larger. It may last for 5 hours, or it may be stretched up to 11 hours depending upon the events that are happening, or blood loss that is there during surgery. So after the surgery has been completed, sometimes during surgery the subjects are being given some part of a rabbit or a horse specific ATG, that is anti-thymoglobulin, to prevent acute rejection of a donated organ. And after surgery, immediately the subjects are put on at least minimum 3 medications that are called triple immunosuppressant. And this image is showing there are various forms of immunosuppressants that are used, and each and every subjects are getting the steroid, that is prednisolone. But as we are all know that there are various pros and cons of use of this steroid during the phases of the medications. But unfortunately, all these transplant patient has to take the minimal amount of steroids for a lifelong period. So you can imagine how much the physical deterioration or deconditioning they must be facing during their phases of recovery. Because usually the immunosuppressant doses that are used immediately after transplant are at the peak level or optimal level, or they are at the maximum level. So in the during the period of immediately after transplant up to 1 to 3 months, the doses of this immunosuppressive medications are at the maximum level. So the immunocompromised status is at maximum level during initial 3 months after transplantation, and after that there is a tapering in the dose, but that are maintained for lifelong period. And sometimes some subjects faces some amount of acute rejection or chronic rejection. At that time again these medications doses are being increased. But we have to remember that these medications are play essential role in the maximizing the graft protection and survival. So we have to educate them to do not has suddenly stop with medication, and because of these medications only this work the organs are working nicely. But on the other aspect, we have to remember simultaneously that these subjects are highly immunocompromised, and so we have to follow all the aseptic precautions when handling with these patients. And transplantation is not a one-handed crown. So the role of a team is very important. And in the transplant team, the transplant physician, transplant surgeon, transplant coordinator that coordinate with the surgeon, physician, physiotherapist, dietitians, patients, counselors, and all are very important. The physiotherapist is an inevitable member of a transplant team, and that will help to deal with the health problems before transplant and after transplant, like to prevention of the various health problems, early detection of any other problems, and to re-educate how to solve the problems and how to rehabilitate. That is to gain HU and based organ transplant results. So coming to the transplantation rehabilitation, that is a bridging the gap for spatial population. As such, there are no special stages or guidelines that are presently for a transplantation rehabilitation in India. But as for in our institute, we have divided the rehabilitation in the various stages. That is rehabilitation that starts way before the patient is been on the transplant registry. That is rehabilitation for end stage organ disease. And once the patient is being coming into the nephrology or abdominal organ transplant OPD, and they refer regularly to the physiotherapy department where we are assessing them, and then they are re-educating for their or making them fit for a transplant surgery, and then we are re-educating what is a transplant process and how the phases of transplantation will be carried out. Immediately then the transplant is happening, and then immediately after transplant the acute care phase comes, that may last for either 1 day or sometimes stretch to the 7 day or 10 day depending upon the patient's ICU stay. Then once the patient is out of ICU, then in the ward, the early post-transplant care is starting. That may last for 2 weeks, 4 weeks, or may stretch up to 1 month. And then a recovery phase when the patient is being discharged from the hospital. And then after 6 weeks or 3 months, the maintenance phase will start. Before coming to any rehabilitation protocol and anything, let me explain something about pre-exercise safety screening. Because I mentioned that these subjects are very much physiologically deconditioned, not any single system that is being left affected. So we have to check for their disease-related safety, cardiopulmonary safety, and impact of other comorbidities before prescribing or enrolling them for any form of physiotherapy intervention or exercises. As for example, like in the kidney disease patient or patient on hemodialysis, they may be anemic, they may be suffering for various proximal muscle myopathy or specific type 2 fiber myopathy, they may be suffering for hypertension, they may be suffering from various form of prolonged bleeding tendency, because of they have reduced platelet count, they have increased international normalized ratio or INR. So they have bleeding tendency, they have energy deprivation, they have fatigue. So sometimes the subjects maybe came for a liver transplant because of they are being diagnosed with the Wilson's disease, that is accumulation of copper due to in the liver and other tissues. And so what is the problem here we are facing it? They have also having in various neurological deformities, neurological involvement, extra pyramidal signs and symptoms. So the phases of rehabilitation may prolong because they also require extensive cardiopulmonary as well as neuro rehabilitation. Is for example in the subjects who have been diagnosed with hepatopulmonary syndrome, that is when because of the hepatic failure their pulmonary system is also affected. They have pulmonary hypertension, they have portopulmonary syndrome, so they have central cyanosis, they have their ABG will show reduced PO2, they have difficulty or breathlessness in the lying position. So we have to deal differently with such populations. They have altered, they have delirium because of their uremic collection, they have various form of encephalopathy and balancing issue. So all these factors should be analyzed before imparting them into the exercise plan. The medical clearance is also recommend from is required from the medical and surgical team. We have to seek or check the recent electrocardiogram, 2D echo, their ejection fraction, their pulmonary function. They may be having certain forms of obstructive or restrictive diseases. And when the subjects is under the dialysis, when we have to check proper history regarding their any hemodynamic response during dialysis, because they may be having a hypoglycemic attacks, they may be having hypotensive attacks during dialysis. So we have to educate them regarding that. I forgot to mention one thing, that the subjects who are on maintained hemodialysis, to make access for a dialysis, they are either there is a central line from where the access for dialysis. That dialysis is a machine that exchange of various fluid and electrolyte happens, and it forms a artificially kidney where most of the time that the blood is circulating through this machine to clear the waste material. But the this dialysis takes every 4 to 5 hours, and the subjects has to take this dialysis for minimum 2 to 3 times a week for a lifelong until they get a transplant. So during this phase we have to re-educate the needy person regarding how we the physiotherapy can help to sustain or improve their fitness level, that is current fitness level, and to make an improvement in their strength, endurance, and quality of life. In the foreign literature, they have specifically designed to how to measure the physical function and functional capacity in the subjects who are having a various form of chronic kidney diseases or end-stage organ chronic organ diseases or end-stage organ diseases. So we have to measure various level of physiological impairment either using laboratory method. We have to measure the mobility and performance capacity of the patient by using various levels of field-based techniques. We have to measure a physical activity of a current level, and then based on this all evaluation, we can make a plan, or we can make a view that how the subjects will progress. And all this physical functional and physical capacity evaluation should be done at a certain period of time regularly to evaluate the progress or deterioration in their level. Coming to the various example, like various maximal oxygen capacity, that is VO2 max analysis or submaximal exercise test can be performed in the laboratory. Evaluation of muscle strength, power, endurance should be evaluated before transplant and during various stages of transplant. The 6-minute walk test is a validated tool for abdominal organ transplant candidates or recipients. And the other various forms of field tests are intermittent shuttle walk test, gait speed test, stair climb power test, repeated chair stands like 1 minute sit to stand from a chair, or a 5 repetition sit to stand chair test. There are the functional tests, that is time up and go test, that will evaluate the balance as well as the strength of the subject, and walk, stair and climb test. All these are validated tool to evaluate their physical function in the subjects with end stage organ disease. To evaluate the activity of daily living or physical activity, there are various other guidelines or other tools that are also validated, that are the SF-36 to evaluate the quality of life, or international physical activity questionnaires are also frequently used in such population. Coming before transplantation, I will covering the aspects of how we can re-educate the subjects before transplantation. I have divided into the two parts. That is the re-educating the subjects who are being opted for kidney transplantation, and other is re-educating the subjects who are being opted for a liver transplantation. So coming to the subject, how to re-educate the subject pre-transplant, before pre-kidney transplantation. That what we are doing in our center is we are dividing the re-educating them the exercises during dialysis or exercising on non-dialysis day. Subjects who are coming regularly in the dialysis centers can be trained or for exercising during their phase of dialysis, that is called intradialytic exercises, because in their 4 hours of dialysis it is safe to perform exercises in initial 1 or 2 hours of dialysis. And it has been, the studies have shown that these exercises during dialysis not only improve the efficacy of dialysis, but it also improve the strength and aerobic capacity of deconditioned subjects under dialysis. And when the subjects are on the other day of dialysis, it is the subjects are taught to remain active. In that way, we are re-educating or improving their fitness level. So what can be done for the subjects who are being on the waiting list for liver transplantation? So there are specific guidelines to re-educate them, because as compared to the kidney candidates, the liver candidates are more energy deprived. They have decreased diet, and they have lots of restriction in the diet, and they have huge ascites, and that's why we have to prescribe the exercises that are vary in a small amount, that is called non-exercise thermogenesis. We advise them to do a daily course of activity and then incorporate breathing exercise in between that, and take a small amount of exercise bout, and then take a large rest, and it should be frequently and imparted during the various phases of day. There are specific guidelines are available, like in the ACSMs and American Heart Association guidelines for exercise testing and prescription for such population exists. But unfortunately, after transplant, these exercise guidelines are not available. And so the principle is start low, progress slowly, and be alert for symptoms, because it is been expected that the various abnormal hemodynamic parameter can be observed during dialysis. So it is advisable initially all these subjects should exercise under strict supervision, and once they are mastered, and then only they should be taught home exercise program. So imagine now the transplant has been happening, that is the kidney transplant or liver transplant has been happening, and the patient is in the ICU. So what care we will be taking? So earlier I told that because of the highly immunocompromised status, compromised status, we have to follow special standard precautions. We have to thoroughly wash our hands, wear the gloves, wear mask, gown, apron, before touching or going in the ward ICU of the patient. And then the second thing is observe everything before doing anything. We have to check for the reversibility of anesthetic agent, because the longer lasting surgery awards, it is possible that the patient may be intubated and sedated. We have to check for their Glasgow Coma Scale. We have to check for the reversibility of the anesthetic agent, whether the patient is alert or patient is completely sedated or paralyzed. We have to check for the respiratory monitoring, whether the patient is on artificial respiratory support like mechanical ventilator, BiPAP, patient is been intubated or spontaneously breathing, or whether the patient is on oxygen support. We have to check for the hemodynamic status, like whether the patient is on inotropic supports, whether the patient is under the monitoring or pulmonary arterial catheter, like that. We have to also check the neurological status, because of it has been seen that because of the longer hours of surgery, it is possible that such subjects may presented with a various form of compressive neuropraxia. Not less than 10 subjects I have come across that they have developed any type of foot drop or a brachial plexus neuropraxia or a wrist drop because of the wrong ergonomics in the surgery. So at our part, it is very important aspect and not to forget to take a neurological evaluation at that stage. The other assessment is incision site inspection. We have to check for any local temperature, the area of incision, or whether there is any oozing is happening or redness in the incision, or we have to, if the patient is alert and conscious, we can ask for the amount of pain the subjects are facing during incision, because sometimes it happens that because of acute rejection, there may be a severe intolerable pain the patient may be facing, and because of that the hemodynamic parameter may be altering. And looking at the various reports and laboratory investigations, the radiological investigations, we can have an idea about how the implanted organ is in function. That is called allograft function. We can check. I'm not going in that much detail of how to evaluate the allograft function. And regularly in the ICU, we have to check for the chest X-ray and arterial blood gases analysis to evaluate as our basis of pulmonary hygiene, and focus how much and how many times the chest physiotherapy will be required. And during the phases of chest physiotherapy, we have to monitor if the saturation is reducing less than 90%, if there is a change in the blood pressure, increase or decrease in the 10 millimeter of mercury of blood pressure changing in systolic or diastolic, when the heart rate variability or any change in the ECG pattern is there, then we have to require the advice, or we have to communicate with the authorities or a nephrology or a surgery team or intensive care team to immediately look at the place, and then we have to stop the physiotherapy what we are giving. And it is important that if the subjects are doing breath holding more than 3 seconds, it is strictly not advisable. That will increase the blood pressure, and as these subjects are suffering from various form of hypertension, it is not advisable. Other form of the complication that may happen during these immediate phases are acute rejection, cardiogenic shock, or transfusion related acute lung injury. We have to think regarding that. Immediately after the transplant, it is possible that there are lots of drains may be attached to the body. There are urinary catheters, there are wound drains. We have there are various catheter Vigos are going on. Sometimes dialysis catheter maybe in the internal jugular vein, or sometimes it is possible that the femoral lines will be there. So we have to evaluate, and we have to check their integrity before mobilizing the patient. That is most important. Patient may be experience some discomfort or pain around the wound. The patient will be able to sit out of the bed with the help of nursing staff the day after operation. So in this first phase of immediately after transplant, usually the patients are in the ICU. So our goal is lung hygiene and improve the circulation and to prevent the deep venous thrombosis. And so all the aspects of lung hygiene, the airway clearance techniques to improve the thoracic mobility and to maintain the thoracic mobility, to improve air entry, to prevent atelectasis, whatever steps to be taken like diaphragmatic breathing, upper lateral costal breathing, lower lateral costal breathing, and posterior segmental breathing, turning the patient, early mobilization of the patient if possible, and if the hemodynamic parameters are allowable, it is advisable to start sitting on the side of the bed, and then dangling or knee extension and pumping exercises are started immediately on the day of the surgery. Inside spirometry has been advisable, and it is in the initial phases every 2 hourly. Specifically the inspiratory exercises are being taught to the patient. And on the day after the surgery, the patient is usually, with the help of the staff, is made to stand on the side of the bed, and if possible, with oxygen or without oxygen, they can do a various walking inside the ward and outside the corridor of the ward. And after that, when the patient is been discharged from the ICU and then been transferred to the ward, gradual progression in the exercises are made. Increment in the intensity and the frequency of exercises are started from this phase, and the patient can take a longer and more frequent walks. And obviously, we are analyzing their hemodynamic parameter and 6-minute walk test during these phases, and then every day we are maintaining the chart, so that we can see the progression or deterioration of the patient. And here in this phase also, the lung hygiene and the management of the respiratory and circulatory system is very important. The very important message that I want to convey is we have to advise the patient to avoid certain things. Which are they? They are being advised to do not lift, push or pull objects heavier than 7 or 8 kgs. Educate to avoid activities that causes pain or stretching or pulling across the chest or raise intra-abdominal pressure, and that they have to maintain this limit till the sutures are healed, and that internal sutures are healed. That is usually 3 months or 4 months after transplantation surgery. And let me explain that there are various challenges one may face during the phases of transplantation rehabilitation, and these are the photographs that I have collected and then put over this in the single slide. That earlier I told that there is a hepatopulmonary syndrome. So there is an involvement of pulmonary system because of the involvement in the hepatic system, because after transplant the organ may start functioning immediately, but the physiological system and other physiological system take some time to retain or regain its normal physiological system. So like in the hepatopulmonary syndrome, the subjects may be presented with the clubbing hands and cyanosis, and the subjects have platypnea. So these subjects, we have to monitor them, and then we have to re-educate them only in the sitting position. Another example is a Wisland disease, when there is a various extrapyramidal symptoms are being seen because of the collection of copper in the basal ganglia. Can you able to identify this, that I have put a yellow ring in that? Because of that, they are maybe presented with the various involuntary movements and chorea, athetosis. Along with that, after such a major surgery, managing them and early mobilization is a challenge to the physiotherapy. But with a successful team approach and a periodical neural and pulmonary hygiene technique, we can rehabilitate such patient beautifully. Sometimes it may happen there may be a segmental or lobal atelectasis, and so I'm sorry. Early and a focused physiotherapy can prevent the development of such segmental and lobal atelectasis or development. Then when the various there is a possibility that this is the image. This is the image of a child who had got a kidney transplant and he's been had a renal osteodystrophy. Can you able to register that there is a deformity in the knees and foot and wrists? Because of that, they have a very fragile bones. So we have to implement a program different kind. So it is an individual approach should be made and evaluate each and every subject to make a tailor-based approach for everybody. There was a one case that been diagnosed as after surgery because of the sudden decrease in the sodium. They had a cerebral pontine myelinosis. They are presented with the acute quadriplegia, and then we have successfully rehabilitate that patient by a special equipment that is called Motomed motor, active or passive cycling, and then early physiological tiltable mobilization and early mobilization. We were able to re-educate such patients beautifully. So my goal of conveying all this thing is, it may possible that in your clinical practice you may come across such type of patients. So it is a beautiful branch and beautiful subject. So we have to thoroughly investigate such patient, and there are lots of scope to rehabilitate such patient, and there are beautiful results we may get. After the patient is been in the recovery phase is over, and then they are in this they are allowed to be in the community, same level of expertise and attention is required as a transplantation team, because as a part of patient itself and as a part of transplant team, it is a lifelong commitment. And successful and long-term outcome in the transplant is only possible by practicing continuous diligence and attention to the patient's need, because this patient will be continuously coming to physiotherapy because they have to take a lifelong immunosuppressants, and so they have to come regularly for follow-up till their organ is being sustaining the function. So each and every time we have to follow up them regularly. We have to follow up their physical function, deterioration, progression, implementation should be done, so that they have to we can make them perfectly fit into their family, into their environment, and into the society. These are the certain images that were happened unfortunately because of late complications after transplant. That is post-transplant lethal pneumonia, that is pneumocystin carinii pneumonia, that is leading to the cavitary lesions in the bilateral lung field and then resolved with the fibrosis. One of the patient had developed avascular necrosis of the femoral head because of the lifelong sustained immunocompromised status that lead to calcaneous bone deformations, and because of the hairpin arterioles are being destroyed in this neck of the femur, they may be presented with pain in the hip, shortening in the limb, or effusion in the joints. This image is showing the surgical hernia and collection of lymph, that is called lymphocele in the kidney transplant incision. And because of the immunocompromised status, now everybody is aware about the mucormycosis, but previously also this immunocompromised post-transplant patient may possibly develop various form of lethal fungal infection that is life-threatening. Studies have shown that the subjects in their recovery phase or in their community phase, if they maintain the physical activity, their cardiovascular mortality is reduced. The orange line is showing the active subjects, the sky blue line is showing the moderately active subjects, and the dark blue line is showing inactive subjects. The mortality is relatively high, the subjects who are inactive, and so that is why the Taylor approach is necessary for a unique clinical concern, their personal consideration, their present capability of individual, and to determine their basal level of physical activity, and to do a gradual progression of physical activity. Do I have a time? Hello? Hello? So, so in the late phase, subjects are having abdominal obesity. They are poor physical function because of physical inability and immunocompromised status. That will lead to cardiorespiratory deconditioning in the late phase. There is a low aerobic power, endurance, and muscle strength. So how to re-educate such subject in the late phase is there are various guides. Such there are no Indian guidelines, but there are various international guidelines. They are suggesting the mixture of flexibility, aerobic, and strength training that should be incorporated in the daily life. And the aerobic exercises and that are based on the FIT principle, that is frequency, intensity, time, and type. Aerobic exercises should be prescribed on 3 to 5 days per week. Intensity are judged either through the heart rate max or a rate of perceived exertion or a fatigue level. And then the form of exercises are advised are usually walking or cycling or continuous larger muscle group exercises that are being performed continuously for 20 to 45 minutes. The strength training are usually advised 2 to 3 days, that is alternate day a week, and usually after assessing the 1 repetitions maximum, either stretching from 50% to 70% of their individual 1 RM, and they are being advised no lifting or pushing or pulling more than 7 kg for initial 3 months, and that are usually light resistance exercises and prescribed in the form of sets, and high repetitions with low resistance exercises are performed. And the flexibility exercises are major muscle group. They are being advised do not hold the breath and for more than 30 seconds, and then gradually dynamic type of flexibility or stretching exercise should be taught. Avoid ballistic stretching or sustained stretching. This is our mentor, Padma Shri, late Sri Dr. H.L. Trivedi sir, who had a vision to develop a world famous kidney institute, and which is presently been a leader in the consider in the Asia, and in the history there are more till date more than 8,000 kidney transplantation, more than 350 liver transplantation, and 7 pancreatic transplantation has been performed. This institute is also managing more than 50 dialysis center across various districts of the Gujarat with the collaboration of government of Gujarat. And I'm very much proud to having this part of this institute. And recently, most of the multi-speciality hospitals are now routinely performing the transplantation. And so I hope I have justified this topic a lot. And there is still a lot more to explore in this topic. Thank you very much, all of you.
Thank you, Harda, for sharing your valuable knowledge, not only knowledge, but your clinical experience here. So thank you so much for accepting our invitation from all the team of Parallel Institute of Physiotherapy. Dharman sir, over to you.
Thank you very much,
Thank you,
madam.
Harda ma'am. Thank you, Bhavna ma'am.
Thank you very much,
Harda
Dr.
ma'am, it was a wonderful session. And like I said in the beginning, this is something, or we can say this is an untouched topic in physiotherapy. Because what we see daily is a routine patients of physiotherapy, which we have been seeing since years. Physiotherapy in dialysis or physiotherapy in organ transplantation, I think very few of them must have even heard about it. Forget about knowing the topic or knowing things what is within this transplantation physiotherapy, but many of us are still unaware that yes, we do have role in transplantation as well. So thank you so much, ma'am, for creating that awareness, giving a wonderful session, a knowledgeable session for our students and everybody who is watching us here on Google Meet as well as Facebook Live. I hope every one of you must have gained a lot of knowledge and things about transplantation and physiotherapy in transplantation. And for any other queries, you can approach Harda ma'am. She's always there for us. She can guide us better when it comes to transplant physiotherapy. Thank you, ma'am. Thank you so very much.
Thank you once again. I'm always open for queries, and or you can meet me on my WhatsApp. This is my mobile number is the same WhatsApp number, or you can dial up me. I'm always ready to help out and solve the queries. I hope I have justified the topic because it is a very wide and topic, and there are a lot of depth in this topic, and I hope everybody's have enjoyed or not. I have not bored anybody.
No, no,
Thank you
it
very much.
was really interesting because, like I said, ma'am, this is like you said, it is a very vast topic, and we need to go into the depth of everything when we start with physiotherapy in transplantation. But your lecture or your webinar was very interesting because you almost tried to cover everything that is included in transplant physiotherapy, right? From what is transplantation to what is the role of physiotherapist, what is the team that is included in transplantation, as well as what are the complications that may occur secondary to transplantation. So I think from A to Z, probably everything you have covered. And yes, it was really enjoyable, ma'am. Thank you.
Thank you very much.
Thank you, ma'am. Hope to see you again soon.
Thanks a lot.
Yes, ma'am, you can do the meeting.
Yes.